So moving from the first line setting into patients who've progressed on therapy, now that we're using immune checkpoint inhibitors up front, what are you doing next? For a while, all that we had were single agent therapies. Are we back to single agent docetaxel with or without ramucirumab? What are you offering your patients in the second line once they progress on a checkpoint inhibitor?
I think this is one of our more difficult questions because today's successes create tomorrow's challenges. And I think, unfortunately, after the 3-drug combination of chemoimmunotherapy, the standard would be single agent docetaxel or docetaxel with ramucirumab. And I think that both of those have activity and they're sort of validated, but I think they're a little bit less appealing to some of our patients who come to academic centers, and we're trying to get a lot of these patients on trial, and that's the real focus. But I think single-agent chemotherapy would be the standard answer right now, unfortunately.
You're doing a similar...
Yeah, I've generally been using docetaxel ramucirumab in this setting. I agree with you, though. Certainly at our centers, we tend to look at a lot of clinical trials in this setting, and there is a challenge. Patients are not that enthusiastic about these approaches, and I think that in some ways it's unfortunate because I do think there'd be some benefit that they would experience by going back to a chemotherapy-based regimen, but it's been a little tough to get them that excited about it.
Now, if with the immune checkpoint inhibitors, we've heard a little bit about those patients who are rapid or hyperprogressors. And there was a subset analysis in the Revel study. Now, granted, this was before we were using the checkpoint inhibitors, that maybe patients with less indolent disease who are more rapidly progressing, and you were the lead author and a key investigator in that study, maybe those patients had a better benefit with docetaxel and ramucirumab. Does the type of progression or where they're progressing or how quickly they progressed impact what you're doing in the second line setting?
So I think that in some of the second line angiogenesis inhibitor studies, there has been enthusiasm about looking at people who are rapidly progressing. This is a group of patients who stands to not do well, and I think it's also important because it's a group of patients that oftentimes we'll see maybe don't get treated in a setting where we now have data in secondary analyses, for instance, from Revel that would indicate that those patients would benefit. Obviously not people whose performance status is very poor, but in people who maybe do have either they've progressed on their initial therapy or they have rapidly progressive disease, that subset does clearly benefit and appears to maintain benefits sort of on par with what was seen in the Revel study in general.
So it is something you can consider. Now, Tom, is there a time factor? So, in the second line setting, if a patient maybe got say we've got a squamous cell patient, because we know that ramucirumab, you can give it in squamous and non-squamous, and they got their taxane and then they were on maintenance pembro for 18 months and then they progress. Do you think about that patient differently than the patient who maybe progressed on like 4 or 5 months? Are you going back to a platinum doublet or how are you, there's no clinical trial, because clinical trial is always our right answer, right? Yeah, so there's no clinical trial. How are you approaching that patient?
So this is difficult, and I think prognostically, I think that patient's a better prognosis patient, and most of the time they have a better performance status. So I am a little bit inclined to be a little bit more aggressive in that patient. Especially, and so I think maybe the double agent docetaxel ramucirumab potentially. The patient who progresses very rapidly, I have concerns that that's a very aggressive disease, and I've taken my best shot with the 3-drug combination. I think that's the person I'm more inclined to maybe do single agent or think that we're going to have a conversation about prognosis and other things, because I'm a little bit more worried about that patient. I've not gone back to a platinum doublet after an interval. That's just my practice pattern. I'm not sure if you all do that.
I think that it's, we had all our management sort of settled for a while, and then with immunotherapy, it's sort of shaken everything up. I've tried not to go back to those decisions that we sort of made as a community before, the sort of not going back to platinum, those sorts of things. Whether that's right or wrong, of course, we don't have any data, but at least to date, I've generally not revisited those sort of, 4 versus 6 cycles of platinum? Do you bring back platinum? Do you go up to 225 of the taxane? Those sorts of things. I've tried to sort of stick with where I was before this, at least so far.
Now, and not to forget, the patient who gets a first-line PD-L1 single agent, that's a very different patient. That patient should get the
Yes,
platinum
thank you.
doublet.
Yeah, that's the
So that's an easier one.